over a few numbers for today. If you look at testing throughout the Baptist system, we have done a total of 926,337 PCR tests. System-wide, we've tested 507,874 people, and that total positivity rate was 17.2%. If we look at current hospitalization numbers, if we look at Baptist Memphis, there are 8 people in acute care non-ICU beds with COVID-19, and there are 6 people currently in the ICU with COVID-19. 5 of those 6 people are on ventilators, I should say, and there are 2 people of those 14 who are fully vaccinated. Of the 3 admits over the last 24 hours here with COVID-19, none were fully vaccinated. Baptist DeSoto numbers, there are 10 people on the in the non-ICU acute care beds with COVID-19 and 5 in the ICU. 4 of those 5 remain on ventilators, and they did not have any COVID-19 admissions over the last 24 hours. I would just say in summary, the numbers are much, much better. We came down to, I think, 11 at a minimum at the end of last week or over the weekend, and then they kind of bounced back slightly into the 15, 16, and 17 range, which is kind of where they have stayed over the last few days. So all a whole lot better. But I would tell you, the honest truth of the matter is that I have heard about and talked to people with and provided monoclonal antibody for a lot more cases over the last week or so than we had seen in recent weeks. That is not to say that that is a trend, but certainly it gives pause, because that's the way I think we've seen it before. I mean, I've said on a couple of occasions, most importantly, kind of in the beginning, and then also at the Delta uptick, we just hear about more cases. I'm just getting a lot more phone calls. Stephanie Yarber, our head nurse in the monoclonal antibody clinic here, the infusion clinic that we have, has had the same thing. We've worked a few people in there. So it does get your attention, particularly in light of the fact that we see these cases worldwide having stopped the decline, and it's sort of leveled off. And we even see cases peaking quite a bit in Europe right now, particularly in Germany and some Eastern European countries. So I think we have to be a little careful. Obviously, it's a time where we're backing off, we're opening up to international travel. All those things are appropriate with our numbers being less. But we saw before that we weren't ready to see things come back. And so we certainly want to be careful about that. But just more to come. I hope less to come. But we'll see what those numbers look like over the ensuing week or so. Happy to answer any questions if anybody has any.
Hey, Dr. Threlkeld, it's Corinne. How are you?
I'm good, Corinne. How are you?
I am doing all right. I apologize. I logged on a minute late. Would you mind just giving a quick rundown again of where the hospital numbers are at?
Yeah, of course. At Baptist Memphis, there are 14 total in the hospital, 8 in acute care beds and 6 in the ICU, and 5 of those 6 are in the intensive care units. There are 10 on the floor, non-ICU beds at DeSoto, and 5 in the ICU there. 4 out of those 5 are DeSoto. So though those numbers remain down, they've sort of leveled off in the teens. And I would say, as we have seen before, and I think you actually asked about this before, many of those people left in the ICU, at least a high percentage, are on the ventilators, because many of them are cases that have been in the hospital or people that have been in the hospital with cases of COVID for many weeks now, some of them. We've lost a couple of those in the last week or so. They obviously have been desperately ill at some point. Many are on ECMO therapy, and some others are very slow to recover. So we've kind of seen that pattern for a while. A majority of the people left in the ICUs are quite ill, and we haven't been, thankfully, refilling our ICUs with COVID-19 patients as much. Though, again, the caveat would simply be that we have heard about more cases. That's what we saw when things turned north before. We hope that won't be the case, but it's something that bears watching, because obviously that's what you see first. And then only then do you see a week or two after that hospitalizations start to tick up. And so we're hoping to avoid that. But that's the numbers for now.
And as we've started to see, children getting vaccinated, I know a lot of parents have been worried about myocarditis or other side effects from the vaccines. Have you heard or seen of any children who have had any adverse reactions to the vaccine?
I have not personally, since we had that approval. I mean, obviously, things are like these things tend to mimic what we saw in adults. There'll be a lot of people who are eager to go out and get their kids protected. There'll be sort of a very large number of vaccinations right away, and then it'll probably quickly taper off, as we saw kind of in the adult population. I think that you'll see a few, vaccine side effects as we go. I think, unfortunately, both sides of the argument about vaccine safety have become ideological a little bit, and that's very that causes distress. I think the numbers, thankfully, if you look at myocarditis, really mimic other things. There have been a couple of news reports about the cases of Guillain-Barré syndrome, something that you will just see very rarely in vaccines and vaccine trials, and certainly when millions of people across the world get the vaccine. So we will eventually see there be some side effects in kids, just as we saw in adults. But the important question is which is safer? And I was talking yesterday about this, and yeah, it's true that kids are a lot less likely to get severely ill than adults, and the rate of severe disease is 99.7 or 8% chance that you're not going to have severe disease. But if you turn that around, COVID-19 was still one of the top 10 causes of death last year in the age range of 5 to 11. So you can make these things sound positive or negative depending on what your ideological position is. I think the key is to try to find the truth and get there. When you see, you're going to get reports, and the interesting thing is that they will make a lot of news when you see side effects. And thankfully, large part the reason that is that they are rare when they happen, and so you don't really see the numbers on people who are protected. You don't prove negatives of people that aren't getting sick because of that vaccine. But unfortunately, you'll see people who've made up their minds that vaccines aren't good, and they're kind of against the vaccines. And for every one of these reports that we're going to get, of course, they're going to say, "See, I told you this is a terrible thing. The vaccine's a terrible idea. It's dangerous because of this one person who had the side effect." And so what you have to remember is, what is the safest path? And the safest path, even if you talk about myocarditis, you're much more likely to get the rare complication of myocarditis from the infection than you are from a vaccine. And so take the safest road is typically the best advice. But I think one caveat that we have to think about is also to be honest and open and transparent about the fact that we are going to see vaccine side effects. There is nothing that is perfect in this world, certainly including vaccines. So it's not, there's an article recently, I think that was a very good one, and it was an interview with a guy named Anthony Flint. He was a former Boston Globe reporter, and he had Guillain-Barré after the J&J vaccine, a disease that can be very difficult. It can make you paralyzed in lower extremities. Thankfully, 85% of people recover fully, but sometimes it takes months to do that. And these are kind of autoimmune problems with the vaccine. But the reason I thought that was such an interesting article, and I can actually put it in the notes for today, is that he was very much in favor of everybody getting the vaccine, even given what happened to him. And he was very hesitant to even talk about it for fear of the fact that it would be used against vaccinations. But he said also you have to be careful, because people on the side of vaccines and realizing that they're helpful and they're scientifically sound can also have a callous approach to this based on their ideological sort of biases, because people would tell him, oh, well, that's just only 1 in 6 in a million that happens to. And he points out correctly, as his doctor said to him, that, well, it happened to 100% of me. And so we have to have compassion for those people that have these problems, and we have to point out that they exist. We have to give people real numbers with which to make their decisions. Now, again, I would argue that it is much safer to take a vaccine than not to, because on so many levels, it's safer. Number one, just on the very, as we just said, on the very level of the particular side effect you're talking about, you're much more likely to get Guillain-Barré syndrome 4 or 5 times by getting the infection than you are from getting the vaccine. The same is true for myocarditis. And so what you have to look at is how many extra cases above the baseline levels in our society that people get these things are you really going to have cases because of the vaccine. And again, I think on both levels, it's going to be a lot more safe to get that vaccine. But we have to be accurate. We have to tell the truth about what those numbers are to give people real choices and accurate choices.
And just to follow up, if you can maybe put parents' minds at ease a little bit, obviously, like you said, the data shows children are much safer getting the vaccine, much less likely to get myocarditis from the vaccine than from COVID-19 itself. But if a parent is a little worried, what should they be looking for in their child after they get that vaccine? What type of symptoms should they be monitoring for?
Yeah, and thankfully there's not a lot of sophistication required or healthcare training to look for these sorts of things. I mean, number one, parents are probably more in tune to these kinds of things anyway than a lot of other people are, because they're used to having kids have vaccinations and having some fussiness, soreness, or pain, a little redness at the vaccination site, maybe even a little fever. Those things shouldn't last long. They shouldn't last really much over 24, maximum 48 hours in almost all circumstances. So those sorts of things you sort of expect. But when you talk about important side effects, obviously, trouble breathing, chest pain, anything that's out of the ordinary should prompt a call from that parent to their pediatrician. And obviously, if it's a more serious side effect, go to the emergency room. Thankfully, these things will be very rare, but they won't be particularly difficult things to recognize. They're sicker. They have pains that they shouldn't be having. Those kinds of things should always prompt a call to the pediatrician to ask about it, because you shouldn't worry about trying to distinguish those sorts of things in very minute ways. You can always ask for help about that. But again, I mean, your point is, these things are going to be rare, but they're not as rare as the infection is at causing them also. And that, to me, is the bottom line. You face two roads, and both of those roads are unlikely to lead to important or serious kinds of medical problems. But if one is 5, 6, 10 times safer than the other one, even though both of them have a low risk for problems or damage, most people are going to take the one that's 5, 6, 10 times safer, just because it is, even though the numbers are both fairly low. And again, that does not even take into account the things that we don't understand yet about COVID-19, the long COVID syndromes. I've seen a couple of young people lately who've had headaches and difficulty concentrating, severe fatigue a month or two even after getting COVID. And so we're having these things pop up in fairly large numbers nationally and internationally. These are things that we haven't really counted the cost of yet, or even really collated the numbers very well. And again, not to mention the fact of its protection to society, because those kids are going to get hugged by their grandparents. We're going to see people coming from across the country and farther for the holidays here in the winter months. People are going to be getting together, and they will not have seen their grandchildren for maybe a year or two in some situations, if those elderly people were being protected. And a lot of those people are going to get together this Thanksgiving and through the holiday season, and that's going to be a significant layer of protection to keep those kids from getting the infection in the first place, and therefore passing it along then to other people that might have a harder time with the infection. Now, none of that is key if it's not safe for kids itself. And back to your point and your question, it is safer, in fact, than facing the possibility of COVID-19 without that protection. We can look at that on multiple levels. And it's such a contagious virus, is Delta, compared to the times we have looked at this before, that there's just a lot more likely chance of the kids getting infected. I've seen several related to school, to church Sunday school classes, and so forth, of kids having cases just in the past week or two. And so, we hope that we can get people protected from that, with all of those levels being a help both to the kids themselves and obviously to the broader group around them.
And thank you for bringing up long COVID. That's one thing we haven't talked about in a while. In the recent months, have we learned anything? Have you learned anything new about how to treat some of these long haul COVID symptoms?
Well, I mean, it's frustrating because there's so many avenues that this disease can fairly take. So I think the thing that makes it difficult is that you break kind of long COVID down into 2 or 3 broader or narrower categories. One is simply, one thing that's kind of considered long COVID is somebody who just had a terrible case of COVID and their lungs were badly damaged from the respiratory involvement of the pneumonia. And a lot of those people have difficulty breathing for months to come if they ever recover from that. So that's one way that COVID damages things in the long term. And there may be little to do with that. And they may require steroids longer term to kind of decrease the inflammation of the lungs. That's a very difficult one. There is simply the deconditioning factor. Somebody that is in the hospital or really sick from it from a couple, 3 weeks on end. And I always like to say, for every day you spend in the hospital or lying in a bed from an illness, takes you 2 days to recover from it. So somebody who was hospitalized for 60 days for COVID is going to take a long time to get out of that fatigue, that weakness, and all those things that come with that. And then, of course, probably closer to what you're really asking about, and that is those things that really aren't necessarily as related to the severity or danger of the disease itself. You've got loss of taste and smell, which has made some data has been sort of publicized recently. That can be a very debilitating thing in a lot of people. I mean, not being able to smell and taste is something that you don't really appreciate until it happens to you for months on end. And not being able to smell or taste your food can be an item that is greatly depressing to people. And we've talked before about how you can actually, some neuroscientists are trying to train the brain to relearn that pathway. You might inhale or taste things that have strong and pleasant, typically, we hope, tastes and smells that you might kind of try to re-identify and help those pathways to develop. But I think the difficulty with having new and better strategies for that is that we still don't fully understand the breadth of the problems or what really is causing them. We presume that some of them is sort of an autoimmune sort of spin-off. But I think those things are going to be very difficult to get a handle on, and it may take some time. There are those who hope that because we know an illness that seems to be causing this, we'll have an avenue once we do get better data and discover it to have some knowledge that will fan out and help us with other things like chronic fatigue syndrome, which may be 8 different things for all we know. So people that suffer these long-term sorts of symptoms from whatever it might be, we might gain some knowledge with that. But I wouldn't say that we've made great strides yet, other than simply trying to keep people active, using physical therapy and the like to help with long COVID. But there are a lot of things. There's typically the brain fog. There is the taste and smell that we mentioned, and it can have some other more serious things. We've seen some associations with diabetes. I've seen more than a couple people come in with very bad and acute diabetes that had not had it before, and it came along with their COVID-19. Whether just associated or causative, we don't really yet know. But people have their blood pressure drop when they stand up. I'm just reeling these things off because it's very difficult to get a systematic approach to what to do with these things because there's so many and varied. And I think it'll take us probably a year or two before we even begin to get a firm handle on long COVID or what we can do about it, very honestly. Any other questions? I have a couple from the feed last time, really more comments than questions. But Madeline Murphy asked, what if your child has already had COVID recently? Do they need to wait a certain period of time before the vaccination? And I think that's a terrific question, not just for kids, but adults are facing that problem too. It's one of the most common things that I get asked these days. If you've had COVID recently, how soon after the vaccine? You probably notice, if you kept up with this, that has changed over time. And some people kind of take advantage of that and say, see, people don't know what to do. But part of that has to do with the different variants that are circulating in the community. So originally, when we really just had the Wuhan variant, I think our approach was, and the recommendation was, that if you've had COVID, you don't need to worry about reinfection really for at least probably 90 days afterward. And at first, we didn't really say you needed to go out and get the vaccine right after you have had a case of COVID. And that was a very common question. Now, the reality is that it was just really only one variant at the time. Now, when we started having more variants circulating, first the addition of the Alpha and then the Delta on top of that, it became a different issue. People said, look, get vaccinated right away as soon as you're out of isolation, because we had other variants that might hit you soon afterward that you might have full immunity to. And so that became the prevailing advice, to go ahead and get vaccinated very quickly. But I think honestly, that is changing a bit in that we don't have another variant yet on the verge of hitting us after Delta. So I think that going out and getting a vaccine immediately after you get out of isolation is a less important issue than it was before. And so I'm not really rushing people to do that, though it's probably perfectly safe to do that. But there's not been a lot of clear advice about that. That's the sort of thing that you probably want to talk to your own pediatrician about, is a post-COVID vaccination strategy and timing. A very good question. And again, the same thing really is true for adults. And finally, let's see. Oh, Madeline Murphy again asked, is there another strain coming? And that really ties into to her first question. Thankfully, right now, there's not another strain coming that we can see. There's the Delta Plus variant that has been seen in Europe, but it's not taking Europe by storm. It doesn't, at least by any data that I've seen, appear to be responsible for the surges that we see over in Europe right now. So that's very important. But I think we do have to watch very carefully because those numbers are on the rise again in Europe. And I think it brings to the point, we may have mentioned Colorado, other places in the US right now. The virus has sort of shifted north right now. Maybe that's for a couple of reasons. Number one, it's really torn through the southeastern United States. A lot of people have been infected, so are not going to be expected to be as susceptible to the illness for some time. People up north had not had it come through, and now it's sort of hitting them. They're more vaccinated in a lot of other parts of the country than we are here, but there are still plenty of them. Colorado was ahead of the national average of vaccination. I think it was 62% totally vaccinated as of a couple of weeks ago, but that means 38% have not been. And so you still have enough of those dry leaves on the ground to catch fire. And so the virus can just keep circulating around the country or the globe or however you want to visualize it and still have plenty of people that would be susceptible to it. And that doesn't even mention the fact that people's vaccines and their natural infection immunity are waning over time. So they would be more likely to get an infection, albeit not as severe, but that's more virus in the community. And that would be something that you could pass on to someone who might get sicker, who is totally unprotected and unvaccinated, if not even a high risk group. So I think all those factors are very important because we're going to have a very hard time getting to that herd immunity that we talk about. It's a very contagious virus with an illness that has antibody immunity wane over time. We don't know how much cell-mediated immunity wanes over time. Right now, we're still relatively protected from severe disease if you get reinfected after the vaccine, but you can still get it. And so those two factors make herd immunity very hard to get to or to achieve. And so with that, you're likely to have sort of cycles of this virus coming through for maybe a couple of years to come. We hope it'll get less severe and fewer numbers every time, but it's going to pick off people who are still susceptible. And there's still plenty of people who are susceptible. It's why we keep beating the drum of getting the vaccine. It's how we get to that nuisance level that we hope to get to, more like the common cold viruses that are other coronaviruses. Those viruses also have waning immunity. You can get those things again a couple of years later. We know this about the other circulating coronaviruses in the population. So it's important for us to get there as quickly as we can. That means to have fewer cases. It means to have fewer severe cases. And that really all comes down to vaccination as the main way we can control that. So thanks for those questions. Any other questions? Okay, thanks very much. Have a great weekend.